All right, welcome back everybody to another episode of the Psych Guys podcast. Today we got a very special episode for you guys today. We've got another guest. We've got Dr. Melvin Ways, actually a newly minted doctor. I had a chance to meet Melvin when, actually a funny story, it was my very first day of intern year. I show up to the consult service at our local hospital, dressed in my full white coat, my full physician attire, and Melvin is a third year student at the time. And I believe it was like your last week of the rotation. So you're actually the one that kind of showed me the ropes as I began my psychiatric career. So I always gonna appreciate you for that, Melvin. But otherwise, you had a chance to rotate with me when I was the senior resident running the psychiatry service about a year later after we met. And you were one of the students who auditioned with us. And we were lucky enough to have you match at our program. And you graduated medical school about 2 months ago, and you are one of our newest psychiatric interns.
Thank you. What a wonderful introduction. Thank you so much, guys.
Hey, but I feel like that didn't do it justice, because you're not a normal physician. You are, in terms of leadership, my goodness, your experiences are astronomical, unmatched. It's one of the many reasons why I find you to be such an impressive physician already at this point in your training. So you're honestly involved in so many leadership positions that I can't even keep track of them. Can you tell us a little bit about what you're involved in, who you are, and just give a very brief introduction for the audience?
Sure. So my name is Melvin D. Ways, Jr. I'm from South Jersey, Camden to be specific. I went to Rutgers for undergraduate and then went to Rowan for my graduate degree in biomedical science, which is a master's, and then I also went for my PhD in osteopathic medicine. I'm currently in psychiatry, but during medical school, I had a plethora of activities, like Joon said, where I was the Student Government Association president. I was involved in a Black Collective, which is a group of minority students, particularly Black students, who advocated for student rights that went way beyond just underrepresented minorities. It was something that changed the whole campus. And I'm also involved in community service. My family is full of medical professionals, and we always give back to community and do various things like that. So it's always been something that's instilled in me to just kind of do these things. I never looked at it like I was doing anything out, of the ordinary, but being involved in different activities and taking opportunities like this is something I've always been appreciative of. So, it's just another day when I look at it.
Just another day in the life of Dr. Melvin Ways.
Nothing crazy.
Well, we definitely appreciate you for all the extra time that you spend, having this commitment to bettering your community, bettering the world of mental health, and bettering the profession of being a physician. So thank you so much for all of that. Today, we actually wanted to bring you on because, from what I understand, through one of your leadership positions, there's been some changes in the involuntary commitment criteria that we have here in the state of New Jersey. Can you tell us a little bit about that, Melvin?
Yeah, sure. So in New Jersey, we currently have involuntary commitment laws that provide providers enough time to screen and get a patient committed to involuntary psychiatric hospitals. However, the time is kind of off when we have to get the process done, and we can talk about that a little bit more. It takes multiple parties, sometimes two psychiatrists, as well as a third-party screener. And when all of those processes go through, we sometimes hit the deadline for that time. And when we went to Trenton this time with one of our program chairs and our legal counsel, we went up to Trenton and asked for a 72-hour law for involuntary commitment. So that gives us 72 hours to have both psychiatrists and the screener give all of this paperwork, make sure the patient is appropriately stable to either discharge home, and we can do it before that 172 hours, or commit to an inpatient psychiatric unit, which we know there's a limitation of beds, and getting patients placed, from our perspective, can be difficult. So that's what we had to explain to lawmakers, and they agreed.
Right. Okay, so there's people that are listening to this podcast who are not mental health professionals, who have no emergency psychiatry experience. So, Logan, can I ask you to kind of jump in and lay the frameworks to, frame the discussion?
Right. So, every single state has some kind of provisions to, more or less, take a patient's rights away and force them into a psychiatric facility. I think I can collectively say for the three of us, and maybe even psychiatry as a whole, this isn't always the most fun process, right? I don't find it satisfying. It's not why I chose to go in this field, right? But, it is what it is. There's some individuals who lack the capacity, the understanding, the capability to recognize the severity of their symptoms of maybe it's schizophrenia, maybe it's a suicide attempt, bipolar disorder, you name it. What's interesting about New Jersey, and look, I don't know all the intricacies of all 50 states, but New Jersey actually respects the rights of a patient, you could argue a little bit more sometimes than some other states. Some other states, a physician can force that patient into a hospital much easier than here in New Jersey. Here in New Jersey, like Melvin was kind of saying, there's a crisis worker that has to screen the patient and determine that that person does meet criteria for involuntary commitment. Then what's called 2 PCs have to happen, physician certificates, where these individuals are screened by a physician, and then all that information is presented into for a judge. Does that set it up, I guess, what you were looking for?
Yeah. I think that was pretty good. I think... All right, so hold on. Let me fix your mic first.
Thank you, June.
There we go.
Technical difficulties.
All right, so, just to carry on from that, Logan, you said there's crisis workers involved who do the initial screening. Those are usually social workers. At least that's been my experience here in this hospital. And then you have 2 physicians who need to come in and both agree with the social worker's recommendation for involuntary commitment. And I just want to point out that all those processes are in place, as you stated, Logan, to protect the patient's rights, so that you can't have one person who's kind of going rogue say, okay, I don't like this person, I'm going to take that person's civil liberties away. There has to be multiple people that are involved and who all agree that this is the most appropriate thing to do in that case. And the reason for that is because, well, I think everything goes back to the criteria, right? The criteria, at least here in New Jersey, and it's pretty similar in the rest of the states, at least here in the United States. And the criteria is usually you have to be an imminent danger to yourself or others. Here in the state of New Jersey, also property is included. And all that has to be the case in the setting of a treatable mental health illness. Well, treatable is kind of a subjective word, right? Of course, we can always try to treat it. We don't know if it's going to lead to a good result, but it has to be at the minimum due to a mental health illness. Otherwise, you can't commit them, to a psychiatric hospital if there's no mental health condition to treat. So I think that's the first point. The second point that I wanted to, have this discussion today is because, guys, when I first started psychiatric residency, involuntary commitment is one of those things that made me very uncomfortable. You're a medical student one day, you're spending all your time essentially shadowing. Maybe you get to do a little bit on your rotations, but a lot of it is going to be shadowing. The previous few years, you were just in the classroom, listening to lectures, taking exams. That's what I know how to do, right? And then day 1 of residency, I'm a doctor now, and here's this person who's in front of me who's in a crisis, right, due to a mental health illness, and I'm tasked with the task to essentially take this person's civil liberties away. So it's always made me very uncomfortable at times, because obviously there's cases where it's very straightforward. Like if somebody comes in and they just attempted to cut their wrist, it's like, oh yeah, like I think you should probably be in a psych hospital, and as a medical professional and with the law of the state behind me, I think we have a duty to protect you from yourself and to get you stabilized, because what we know in terms of acute suicidality is your greatest risk of having a suicide attempt is within a week or 2 of the last suicide attempt that you had. So that's pretty much like an automatic. But as you guys are well aware, there's cases where there's a lot of gray area where you don't really know if, there's no lab values, right? There's nothing that we can look at and definitively state like, hey, this is, this shows this, therefore I'm going to act in this way. A lot of it is gathering information based on what the patient tells us, gathering information based on what the patient's family members told them. We get reports on how they behaved here in the hospital, if they were agitated, if they were trying to leave the hospital, or if they were calm, collected, cooperative, right? All these little data points essentially kind of come together to give us a clinical picture, and then we kind of take that and use our training, but of course there's a certain degree of subjectivity involved as well, and we kind of make that decision. So, like Melvin, you might see a person and say, this person needs to be committed involuntarily, but that doesn't necessarily mean that Logan or I would agree with that, right? And that's very common in the world of psychiatry, right? You can go to a psychiatrist and you can see 10 different psychiatrists get 10 different answers, which makes psychiatry a little bit challenging. There's multiple correct answers. There's some wrong answers, but multiple correct answers. So all that's to say is there's this ethical dilemma of how do we best help this person? Do I take this person's civil liberties away, which should not be done lightly? Look, we live in America, right? Our fundamental values is individual freedoms. And as doctors, we need to be very mindful of that. psychiatry is unlike any other specialty because this is something that we deal with very routinely. We're involved in this process of committing a person to a psychiatric hospital. Kind of like, I don't know, I want to say like, it's not jail, but at times you're like, ooh, there's some similarities here. But of course, in terms of mental health, these involuntary commitments, the end goal is to get that person stabilized and get that person transitioned to an outpatient level of care. But there's just certain circumstances where we're not sure if that's the most appropriate thing to do. And some of the ethical dilemmas that come in is like, hey, do I make the choice that's best for this patient, or do I feel iffy enough about this case where I just want to take the safe road, right? Do I just want to be mindful of some of the liabilities, some of the legal aspects, the legal consequences that may come up if I make a wrong decision? So that may also impact the physician's decision making. And I'm sure you guys can understand that there's a very big ethical and moral dilemma there. So, guys,
It's tough.
we did an episode on one of the very first episodes of the Psych Guys podcast. It's episode 2, I believe. And the reason for that, I think, is because it was one of those things that was weighing very heavily on our minds. And we wanted to do this follow-up, not only because there was a change in the criteria, but also because we've also changed, right? We're PGY3s now, third-year residents. You are no longer a med student. You're a fully minted physician. And as we gain more experience, as we gain more experience, as we grow in our personal lives, of course, we're going to have we're going to continue to have and develop nuanced opinions, nuanced views towards these complicated issues going on. So, Logan, I'm kind of rambling here. What are your thoughts about this whole involuntary? Like, what are you, what are your perceptions? What are some of the concerns that you had? Do you agree with what I said?
Right. Yeah. I mean, you did go on quite a rant there. I liked it. I mean,
I
you can just kind of hear your passion, frustration for this issue. And I'm glad that, we're in the infancy of our career, right? And we do take this with extreme caution and thought, right? And, I hope years from now when geez, how old am I? 34? Maybe 35 years from now, I'll still be practicing. I hope I am. I hope I'm not tired of psychiatry at that point. And I hope I still taking a patient's rights away and forcing them into the hospital still with as much mindfulness, concentration, thought, and effort, because it doesn't necessarily, I know it doesn't necessarily feel good for the patient. It doesn't necessarily feel good for the physician. I would direct the listeners to listen to episode 2. I think we had a wonderful discussion. And now that, Melvin, you're here, I actually didn't know all those leadership positions about you. Yeah, so it's really cool that you've done all that stuff. And I want to take advantage of this opportunity for, all of you out there who are listening on just audio. I'm a white dude, right? So I'm not in this category of any kind of minority, right? Although I'm married to a wonderful Latina, my understanding, my experiences with racial issues is, of course, extremely limited as a white dude living in this society. I understand that, there's certain advantages that I potentially have had. There's certain situations that I potentially avoided. Tomorrow I'm giving a presentation on restraint and seclusions for our psychiatric class, but I'll give you guys a little sneak peek. So one thing that I'm surprised, you guys won't be surprised by, is the association of who typically has to get put in restraints and secluded. Men with a history, men who are mostly younger as well, with a history of any kind of aggression. Schizophrenia is typically associated as well. And individuals who are African American or Asian descent are more likely to be restrained and secluded.
Asian? Mm-hmm. Really?
That's
Wow, I didn't know that.
That's at least what the data says. Let me challenge you there. I guess why, when I said black individuals are more likely to be restrained, he nodded in agreement. Mm-hmm. When I said Asians are more likely to, you almost seem surprised. I guess why?
Oh, I'm very surprised. Well, okay, so this is one of the benefits of doing a podcast like this, right? I think I've said in previous episodes, I'm not afraid to look ignorant, and maybe this is one of those moments. I had no idea. And look, I'm from an immigrant Asian community, right? Like my parents immigrated here when I was in the 2nd grade, and I grew up mostly around other immigrant Asian individuals. Mm-hmm. That's basically the community where my parents being non-native English speakers. That was community resources. We used to go to a Korean church where there was a bunch of other immigrant families just like us. And that was just the way things were. That was the community that we had. So that was my world growing up. So I feel like I understand that world very well. And, you know, man, like at least in the Korean culture, we are very passive, I want to say, very meek, especially when we're dealing with professionals. So I'm going to give you an example. Let's use an example of education, right? Melvin, let's say you're my professor. Here we say, you know, like sometimes we call our professors like by their first names, right? It happens at times. Mm-hmm. In Korea, you can't ever mention their names. You have to use their professional title, right? Or otherwise, it's a sign of disrespect. Here's a better example. Okay, so I read this in a Malcolm Gladwell book. I think that's where it was from. But it was a story of, I think it was Korean Airline or Asiana Airline, that those are the two big airline companies in Korea. And there was a plane crash that happened. And the analysis of why that happened is this dynamic between seniority, right? Between authority figures and those that are below that authority figure, right? So you have the captain, and then you have I don't know what the professional title is, but the guy that's right under the captain. Let's call him the co-pilot, but
assistant to the captain.
Assistant to the captain. We'll go with that. Yeah. So everybody in that cockpit knows that the captain is the guy in charge. He's the senior, and he has that title. Mm-hmm. So this guy who was under him had concerns, but because of their cultural boundaries, he wasn't able to express those concerns because, like I said, in the Korean culture, authority figure, aka like, you know, for example, a doctor. You're not supposed to ask rash questions. You're not supposed to challenge their opinions.
How do you speak truth to power?
Exactly. Right. So that's the reason I think I was very surprised. I would figure like an Asian person, you know, especially if it was an individual from my own immigrant community, if I can imagine that individual being brought in front of authority figures, I would imagine that individual to be very meek, very passive, kind of revert back to their cultural norms. Mm-hmm. However, the caveat here is, why were they brought in, right? Mm-hmm. Presumably secondary to an acute mental illness. Mm-hmm. So maybe they're acutely psychotic. And maybe it's a product of the environment that I'm in right now, but I'm going to be honest. I haven't had too many Asian patients here in the ED. The ED that we work in is in Camden, so maybe it's just by the nature of the demographics of the area. I'm not sure what it is. I'd be interested in hearing what the experiences are like in other emergency departments where there is a larger Asian community, and maybe this is just a lack of experience on my part. No. But yeah, that's kind of why I was surprised, just because, you know, culturally, I feel like Asian communities are on the very like timid, and very like, I don't want to say like I don't like these words, man. Obedient, timid. I feel like I'm,
reserved.
You know, there's a negative.
Let's call it reserved.
Yes, because there's a negative connotation associated with those words as well.
Let's call it reserved.
Right. And I don't want to contribute to any
stigma. Generalizations for an entire group of people as well, right? You know, exactly. Like when we say Asian people, I mean that includes even like India, and then Asian is what, like all of Asia is what, 2 billion people? Because China's like
including
1.
Russia.
Yeah, I mean, yeah, you know, like it's.
So Russians are technically Asian.
Yeah.
What do you want? What's your response to that?
And that's what I was going to say, is that there's no monolithic culture. So even amongst blacks, there's like people from the Caribbean, there's people from Africa. So when you consider your culture within Asian, I agree with Dr. Noone, is that there's a variety of culture, including Southeast Asia, including, you know, Asia as north as Russia. So when they say Asian, who are they? Are they addressing your culture or someone else's culture?
Oh, that's very
and
interesting
even,
as well.
you know, going back to the emergency psychiatry perspective and using restraints and even medications, using medications against the patient's will is something that blacks are disproportionately exposed to. It's something that I learned in my research. So that's what we'll talk about that more, you know, tomorrow and today. But I do think that that's something that is a cultural bound, where sometimes they don't understand where the patient is coming from necessarily. Take a black person and say, I don't understand the verbiage they're using. They're telling me they're going to F me up, or they're going to do something wild right now. They're going to, you know, lose their mind up in here, whatever you want to say. That might be misinterpreted in a medical setting. And sometimes the patient might be treated differently because of that. And even to your point, like institutionalization, when we talk about jail, my first rotation as a psychiatrist, I had a black patient ask me that. He said, this place doesn't have a lot of windows. It doesn't have a lot of therapeutic effect when it gives me my liberties, like walking outside and fresh air. And I didn't have a great answer for that because our facility does offer those things, but not in an abundance. But generally, when you're taking someone's rights away, you do limit those kinds of things that make people feel human. And I didn't have a good explanation from that as a person trying to provide therapy to this fellow minority. And it left me at a loss in a lot of ways when we're talking about disproportionately negative effects from our therapeutic, attempts in these populations. And I'm the one that's now administering that.
Right.
It's very conflicting.
Right. I think there's kind of two important factors here. Like I actually had an individual in Camden, and I don't want to release, of course, like a particular, HIPAA violation or anything like that. But this was a man of Asian descent and actually was from a very rural area of China and spoke a particular dialect of Chinese that was not Mandarin, or I don't want to say which it was because it will be, too identifying, but. He did have to get restrained during his hospitalization. I wonder how much factored it in because there was such a struggle to communicate adequately with this person, even with the help of a translator. So I think that's important, right? When a patient can't adequately make their needs known, when a clinical staff can't adequately communicate, there's recipe for disaster. Now, on the other side of the coin, I feel like there's cultural, racial issues too. And the first kind of thing that comes to my mind is kind of like African Americans, and like individual comes in and I don't know what the solution is. How do you fix like culture? How do you fix people's conscious and unconscious bias into these scenarios where individuals get restrained?
And I think what we're doing right now is important, talking about it. Our program chair would be extraordinarily happy that we're even talking about the way race plays into these things, because it's so true when we go home and lay our head down on the pillow. We just took somebody's rights away. So how do we digest that? Do we digest that and process that? And, how do we make that decision? And when it comes to race, I think people have these implicit bias that are just rampantly unchecked. I was exposed to them in medical school. I've been exposed to them throughout my entire life being, the person I am. But when people don't think about that in terms of their decision making, that's when it becomes something that goes into a negative place. But if you go home and you think about it, that's where it at least starts, and you can make a change from there. But ignoring it is always the problem.
Right. I think you said something very important there. When you go home and think about it, right? I think we need to recognize that nobody's ever going to be perfect in the moment. As physicians, we're human beings. We're prone to making mistakes. I may have said something that was off-putting to certain patients that I've seen. And to other patients, I may be like the greatest thing ever because my interaction with them was amazing. It just depends on, so many other things, right? Like what's going on in a physician's personal, like all these things. We carry these things with us. And I don't think the expectation should ever be to get every single situation right. Although, in a perfect world, like who wouldn't want that, right? But in consideration of the reality that we live in consideration of the human potential to be wrong in a lot of circumstances, I think having that reflection, when you're by yourself and kind of walking back through the steps that you did, some of the things that went right, some of the things that went wrong, I think that can be one of the best ways that we can kind of extract as much lessons that we can from even our negative experiences, right? And carry that forward with us, because a mistake is inevitable. However, if you repeat that mistake, right, that's where things, can become questionable. So yeah, going home, reflecting on it, I love that. And we talked about how race plays a role in some of our interactions in the ED. On that note, another thing that I wanted to talk to you guys about was something else that I feel like influences cases that we see in the ED a lot. And that's going to be market factors, the economy, the economics of medicine, right? I think one of the biggest frustrations that I have is, look, when we're in the ED, we're taking care of multiple patients. And I have a person who's actively psychotic. He's banging on the doors. He's banging his head on the wall. He's cursing at the staff. He needs to be medicated, in this regard, right? For his safety, for his protection, for the protection of the staff members.
Yep.
And then in the other room, we have a guy. I don't want to generalize, but let's say he's homeless. Let's say this guy has been in an inpatient hospital 5 times in the past 7 weeks, right? This guy's in and out, and there's a suspicion that some of his reasoning for wanting to go to an inpatient hospital is because it's a warm place to sleep. They give you 3 meals a day. You get attended to by nurses. You have people checking in on you.
What we call in medical terms secondary gain.
Right, secondary gain. There's a professional term that we use, right? This is a reality that we deal with. And the frustrations that I have and where the economics of medicine comes in is who gets the bed first? Is that guy who's not aggressive, even though there's a concern for secondary gain, even though there's concerns that even if we send him to an inpatient hospital, that none of his external factors are going to objectively change in a drastic way, versus this other patient who's decompensated from a psychiatric illness. We know how to treat that. We know what medications to give. We know that we can get that person drastically stabilized. But because he's banging his head, because he's being rude to the staff, the inpatient facilities that are looking at patients to kind of allow, accept into their facility are saying, oh, that looks like a difficult case. No. Let's not do that. Let's accept this other guy. Let's get him in, and we'll discharge him in about 2 to 3 days. And as we all know, when you admit a patient, you discharge him, ka-ching, you generate the revenue, and one's objectively an easier case. But the moral dilemma here is, what is the right thing to do in terms of helping our community with mental illness? I'm not saying that other guy doesn't need mental health assistance, right? He clearly does. If you're coming to the ED several times within the span of a few weeks, if you're homeless, like all these things contribute to the downfall of our mental health. However, this other patient, just because he's violent and he's banging his head, he's rude, there is absolutely a stigma against that. And hey, maybe that's due to his acute psychiatric illness. Maybe that's the reason why we need to get this guy in faster. So I don't know what you guys, your experiences have been like, but I feel like I've seen that way too many times. It's one of the things that drive me crazy.
Right. What I thought was really interesting, kind of relevant to my presentation that I'm doing tomorrow in response to what you just said, is, I always thought like the rates of using restraints in a sense would be based off of the patient, and I talked about earlier like some of the demographics so that unfortunately maybe impact restraint decisions. But like you said, that very psychotic patient that's being violent, that's banging their head against the wall. But then the other side is kind of equally true too, at least potentially. There was this one study that was at the VA, and it looked at nursing staff and other clinical staff's rate of burnout. And the staff that had higher rates of burnout were more likely to want to restrain patients. So I thought it was just so interesting how, like, making sure that our clinical staff is in a good place can actually lead to better patient outcomes. Wow. Or actually, maybe I shouldn't even say patient outcomes. That's a bullshit. That's not true. But I at least could maybe say patient experiences, right? Because I think it's at least fair to say most people don't like getting placed in a seclusion room or in mechanical restraints. For the listener who doesn't know what mechanical restraints are, it's probably as bad as it sounds in your head. We're talking ligatures that are kind of leather, or like these Velcro things that are basically around all extremities. That's 4-point restraints. And then sometimes there's even what's called 5-point restraints, which is an additional belt or device that goes over like the chest or the abdomen.
That's intense. That's
intense.
Really, really. And I mean, learning that, I didn't want to go into psychiatry coming into medical school. So from the layman's perspective, even from the person in medicine perspective, that is shocking. I will tell you very openly, like, that was something I was like, whoa, this is but when you learn more about how this person is a danger to themselves, how they could potentially hurt themselves in the midst of their psychosis, you start to become more amendable to this kind of treatment and say, okay, this is something that's a tool, it's not a punishment. And at the same time, when you look at the guidelines for using these, you reevaluate the patient. You don't use it as something to pacify someone or just to put them in a corner and neglect them, irrespective of your burnout, which is, it's sad. It happens. It's hard to deal with this patient population. And this can be something that is used as a pacifier, but it's not appropriate that way. So I do agree with that, sentiment that it's hard to decide when and how. And like we said before, when you go home and lay your head on a pillow, like, did I do the right thing? But we constantly have to think about and refine this process. And if we're using it disproportionately or we're having negative patient outcomes, we need to think of ways to refine that. And if wellness is a part of that, I think it benefits both.
The moral dilemmas of the psychiatric profession, right? So for the listeners who are not in the inpatient psychiatric setting, I just want to give a little bit of additional information. So of course, in these situations, right, like you don't want to go to restraints immediately, right? That's not. I want you guys to be assured that that's not what we're being taught, right? That is the very, very, very last resort, right? We're always taught you want to try to take the least restrictive method possible to take care of the situation, right? So that always starts with trying to verbally redirect the patient, try to see if you can calm them down just by talking to them.
Meet their needs.
Exactly. And then you can escalate to, hey, maybe you want to try to redirect them to a different room. If that doesn't work, hey, maybe you want to offer them some oral medication that they can take to kind of take their edge off. And then if that doesn't work, maybe we have to give them an IM injection of a sedating medication to kind of take their anger, their acute agitation away, right? So there's steps, right? It's not like we're being taught that this is what you need to do every single time. These are hopefully they're rare. It seems like, living in this world, we do see it from time to time. But yeah, it's supposed to be the very last resort.
Absolutely. And I always agree with allying with the patient. Like, you're not going to be the perfect buddy because ultimately you are the person who's taking away their rights. But I'll try and humanize myself with them as much as I can. I'll go to group with patients. I don't care. I'll sit with them and hear their problems with the therapist, or play ball with them, or, if I can sneak a snack with them, like I'll get me a cookie and them a cookie, or, just really small things. Like, I've seen patients really brighten up off of getting a haircut and feeling like themselves, or having their clothes from home in their pajamas instead of wearing hospital gowns. So really normalizing people, even in an emergency setting, those things are useful. Just really making people comfortable to de-escalate them. Exactly.
And the end goal is to keep the patient safe, is to keep staff members safe, because it's an unfortunate reality of working in the psychiatric profession, especially in these acute, like, inpatient stabilization units, where patients can be aggressive, where patients can be violent. That's a real danger that we do face, and it's something that we do think about. How do we mitigate those risks to the best of our ability? And unfortunately, you hear it from time to time. People do get injured, sometimes very seriously. Sometimes other patients get injured. Sometimes that patient themselves gets injured. Sometimes the patient hurts another staff member. And sometimes it can be really, really serious without getting into the details. So that's always the concern that we have in mind when we're taking these modalities to try to calm somebody down. It's not to take away their humanity, but it's for protection. Like, I want, Melvin, like, you have a girlfriend. She wants to see you go to work and come back, that day. Right? She doesn't want to see you end up in the hospital, and that is a risk in these inpatient hospitals. I think that's something that's on every staff member's mind, if you've been working in this setting long enough. And maybe that sometimes contributes, that sort of fear sometimes at a fault contributes to escalating interventions when it's not appropriate. And maybe that's one of the values that we can provide by doing this podcast. Today, here with you guys, maybe we can say, hey, like, take a step back. There's a procedure, and this needs to be the very, very last step. But at the end of the day, if it comes to patient safety, if it comes to the safety of the staff members, we as physicians have a duty to make sure that our attention is directed in that way.
Yeah, and I think that comes with due diligence. As a new doctor, one of the things I always get asked about is, what's the patient's history? What has this patient done prior to this? And it's really easy to make an implicit bias decision off of someone being incarcerated previously, or having a history of aggressive behavior, or having a history of violence. And in that snap decision you have to make within 70-something hours, you say, yeah, restrain this person because he seems hostile. He makes me feel nervous. And you can justify that in a variety of ways because we're educated. But the common layperson who's trying to control their emotions in a situation that's frankly, really emotional for them, whether it's fear, agitation, anger, it's up to us to kind of divulge all of that in a way that doesn't damn this person, regardless of their history, right? Because we deal with patients who are actually convicted criminals. Some people get off and have a, dismissed case for reason of insanity, or even what's called an IOC, involuntary outpatient commitment, where they're subjected to frequent follow-ups with a social worker, and they have to check in, almost kind of like a parole program, but for your mental health. And it's really hard to say this person isn't going to be violent this time just because they're agitated. And you really have to make a a judgment call quickly if this person decides to feel upset or they're getting upset and say, well, how can I help this person without limiting their rights further and subjecting them to this care that we know isn't, nobody says restraints are effective. Agreeing with Joon, like there's plenty of data that says restraints don't improve patient care. Like these things are well documented. It's not like we're saying this is the norm. It's something that protects everyone and the patient. And that's the hard part to emphasize when someone's on drugs or acutely psychotic or has a history of being aggressive. How do you say that restraint will, help that person? It won't, but it will protect people and protect the patient. And that's when I go to sleep at night, I feel okay about that. And I talk to the patient immediately the next day, however long it takes to, redo the restraints. How about you guys? Like, do you feel compelled to now that you're experienced, do you wake up and say, I wonder how this patient's doing under restraints or,
Yeah, I lose sleep over it. I think and I would actually really push against kind of both of you guys actually in what you just said. I think restraints is absolutely not benign, and I don't know if I would even really agree if it does more not good than good. At sometimes there of course are deaths associated with restraints. It's scary, and I think like Joon was kind of saying like the last resort. I think it's the last resort given the circumstances that we find ourselves in. And I think they're shitty circumstances. If a patient's trying to punch somebody else in the head, like that, of course, is a situation that warrants an aggressive modality. I get that. I hear that. I respect that. But that being said, part of, I think, our role of physicians doing this podcast is we need to be the voice of the people who don't have a voice. When I was presented to the psychiatric facility when I was manic, granted I went there voluntarily, there was no police, there was no crisis workers. But I remember they put me in this room that was not padded, but it was on a bed that didn't have the straps, but I could see where they snapped into. And I remember just getting so incredibly anxious in that moment. And imagine what I was going through, and I wasn't even restrained. There was nothing, it wasn't even close to that. So I think that at least one thing that I want to be really passionate about is trying to change these circumstances. What if we could envision a psychiatric emergency room that looked radically different than what we do now? Because I feel like a lot of the psychiatric rooms looked similar to other medical bays. What if a psychiatric room, I think about what if it could have a punching bag? So you get that agitated patient that comes in, whoa, chill out. Don't punch me, punch the punching bag, man. Just let it all out. Go have fun. I want you to work out. What if it had a spin bike? I want you to exercise. Some of the other things I found in my presentation are things that are so easy that I think we would all agree with, but I've personally never seen done at least all that frequently. Calming music. What if, look at the world we live in now and 20, 30 years from now. What if there was some kind of arcade system? We could distract someone with a video game. Hey, play a video game or whatever to calm them down.
Aromatherapy.
That's funny. You took the words out of my mouth. Aromatherapy was another one. What are all of these other techniques that are less restrictive than restraining someone? Can we really say all those things are ever actually done? I would say rarely. Rarely. I've seen them hardly at all.
And to your point also, not a lot of them are very expensive.
Right.
Aromatherapy is cheap. Even having physical exertion is very cheap in certain respects. Mm-hmm. So I really do thank you guys for making the space to challenge these kind of modalities, because it's made by people who are beyond our years, to be honest. This has been done before we got here. It's not something
in my research it's been done for, they think, at least 200 years they've been restraining patients. At least
200 years. Okay.
Yeah.
Look at that.
Probably longer, if you even think about it, right? The medieval days when they had patients that were, psychotic, they probably did worse things than just restraining them.
Right.
Mm-hmm.
Did you come across any kind of data on the frequency of restraints in the 200-year time span, or however long they've been keeping track?
Oh, it's interesting.
Is it increasing? Is it decreasing? Because we hear workplace violence is increasing. Staff members getting attacked, that's on the rise. So I wonder if that also, on the corollary, does that mean that psychiatric patients at large are becoming more prone to violence, subsequently putting the staff members at risk? So that's where that question is coming from. That's probably a hard question.
Yeah, I wish I knew.
Yeah, that would be interesting.
There was some data about the prevalence of how often these kind of restraints occur. What I thought was also kind of interesting in the presentation that bad outcomes associated with restraints are actually more likely to occur in non-psychiatric settings, so not in a psych inpatient ward. Maybe is that because the staff has less experience? Maybe are those patients more of like a geriatric population that are on the medical floors that already have a bunch of comorbid conditions? Who really knows? But those patients that are restrained, it was like 75% of them live with some kind of severe mental illness. So it's still, the patients that we work with, but not necessarily in our most normal setting.
This is interesting because one of the things I love about psychiatry, and one of the reasons I got into it, is because it's not just medicine, it's life. Like, we kind of look at people's patterns and behaviors as a group and individuals. And when you talk about restraints, the first thing that came to my mind was, well, is it incarceration or is it psychiatry? Again, like, we've used restraints for the incarcerative purposes, since the start. And, as a society, I think we definitely have trended that way. Just overall, like increasing, suppressing the rights of others for the sake of saying, this is justice, or this is how you advance society. And so I, in that vein, I do think that we probably, as a psychiatry community, would trend that way. We are radical nowadays, but I think, again, our thinking comes from archaic ideas. We probably trended that way over time as well. And restraining is the more, we used to have padded walls back in the day in the movies and things like that.
That still is a thing. Don't worry. No. That's still a thing. Best be sure.
And it's funny, I just want to plug this really quick as an idea for you guys, because we've dipped into the vein of forensic psychiatry so much this episode when it comes to IOC and taking away people's rights, and just that, pleading insanity for, reason of mental illness, or pleading insanity and dismissing your case. I really do think you guys should commit an episode to that and bring some of our experts in, because it deserves some type of spinoff into this emergency psychiatry, making that long-term decision. It's really important.
Yeah. That's a good idea. Absolutely.
Yeah, just spitballing, because that's something that's come up multiple times, is like the incarceration system, things like that. And even when you talked about the financial aspects of it, that's one of the pressures that didn't get brought up when you thought about the system of just getting the patient taken care of, who's more psychotic or less psychotic. But just, we're forced to get them out of the ED faster because that patient has to pay a bill. And the longer they're sitting in the hospital, the bigger their bill gets. Are they going to pay it, etc.? And that's the pressure that we have, even with the 72-hour commitment. Like, people are still going to be pressing on us to get this patient out because they need that bed. And it's interesting to even think about it that way. So.
All right. So Melvin, we started this conversation off by talking about the change in New Jersey commitment criteria.
Yeah.
We kind of went off on a tangent. I think most of this episode, we discussed about restraints, seclusions, and I think it was a great episode. I certainly learned a lot. This has been arguably one of the more challenging episodes that I've done with you, Logan, and our guest today, Dr. Melvin Ways. Yeah. So you're already like getting our wheels rolling. We certainly hope to have you back, but before we let you go for this podcast episode, at least, I'd like to wrap up this podcast episode by bringing the conversation back. So the exact criteria that was changed was the time for the physician to complete their physician certificate has been increased to 72 hours.
Yes.
Okay, and where was it before?
It was initially half of that. So, pardon my math, I don't know exactly,
36.
Yes, we are psychiatrists, not mathematicians.
I'm not Pardon me for bringing out my calculator, because my math teacher said I'd never have it. 72 hours divided by 2, 86. So 86 hours to get them out. So it's really something where it just gives us less of a...
Wait, 72 or
172?
Yeah. I was like, this
86?
math is not adding up.
It's 72 hours. Yeah, it was 72 hours, but 172 is now in the new time. Or 100.
Oh, gotcha.
100,
so it used to be 72,
right,
but now it's...
Wait. 72 times 2. Let's see. Is it
142?
142.
No, 144.
144. Okay, 144 hours. There we go.
We figured it out, ladies and gentlemen.
So scratch every time I said 170.
In short,
72.
it's been extended.
Yeah,
okay,
that's one thing. Maybe we fucked up the hours.
Right,
Yeah.
it's been doubled. That was
It used to be 72 hours.
Right,
okay.
Now it's 144.
Okay, and the huge implication behind that is once the crisis screener who starts off this entire involuntary commitment process comes and screens the patient,
correct,
they recommend the patient to be committed involuntarily if that's their clinical assessment, and then the physicians come in, and this is where the change happens, right? We had 72 hours prior to evaluate the patient and kind of submit that paperwork to say if we agree or disagree. But now that criteria has been doubled.
Correct.
And I think the big impetus behind that, and you can kind of jump in here and if I'm wrong, but at least from my experience working in the ED, is because like we talked about when I discussed the finances of hospitalizations, it seems like some certain patients there's not many inpatient facilities willing to take that person, and they just end up sitting in the ED for days and days and days. And previously, before this new change was made, that really put a time constraint on how much time we had to actually search for a bed. So I would argue that this is it may be a Band-Aid, right? It may be a Band-Aid on a big wound, but hey, it's something that's going to help our patients. It's something that's going to help us as clinicians, and maybe that's a great place to leave this episode.